I'm Poortmans. I consider myself rather as a breast cancer specialist with radiation oncology as tool. I'm very happy to come here because I had quite some contributions and I still have some to go. Today, I will rather speak about the management of the axilla, the management of the lymph nodes under the armpit. This is a domain that has seen a huge evolution over the last decades. When I was in training quite some years ago, it was standard the same for everybody, a complete surgical axillary clearance. This led to quite some morbidity, increased the level of lymphedema of a swollen arm, and for most of the patients it was absolutely unnecessary, because if you do surgery and the nodes are not involved, that's good news, but you have the side effects. So we learned to do more targeted approaches. Nowadays, in high-risk patients, we give first the chemotherapy, and then we proceed to the rest of the treatment of the breast and of the lymph nodes. And this challenged us to rethink management of the axilla. And my topic today will be about how to manage the axilla after chemotherapy first, followed by limited surgery of the axilla, of the armpit, and then encountering a node that is involved by tumor. What to do then? The discussion, which is worldwide valid, is: do we need further surgery, or can we treat the patient just with radiation therapy? We learned over the last decades that there is not one type of breast cancer. Breast cancer is a hugely variable disease with a lot of expressions. We call it often the molecular subtypes, but you also have the stage and you have the population in which the breast cancer is detected and treated. However, there are a lot of common grounds, and therefore we need to collaborate internationally. A lot is similar, independent on where of our globe you are or the patient is located and treated. That's why we need to do the things together. Currently, performing clinical research is hugely complex because of a lot of reasons. It concerns privacy, it concerns insurance, it concerns administration, and all that requires a huge amount of money. For having high quality, high level of evidence outcomes of our research, we need often a large number of patients, or we need to do trials in a very small subgroup of the breast cancer patients. And that are all reasons that we need to do it together. We cannot do it in one country and then expect that other countries in another place of the world simply adapt it. It has to be validated. Let's work together for now and for the future of our patients. We know that we improved a lot over the last decades, but still there are very challenging cases where we don't have the real solution, either because finally the tumor is resistant to our treatments, or patients where the side effects of the treatments against the cancer have such an impact that there is life, but of low quality, so maybe even not worth living. This will stepwise improve further. And this can be done thanks to early detection, screening, but this needs to be more focused. We really should not start investigating all women from the age of 30. No, we have more and more tools to learn which women are at risk of developing breast cancer. I love to share my experience, my knowledge, but I also like to absorb and to learn from others. And the interaction, the social interaction between all healthcare professionals and the patients as well is so enriching that it cannot be replaced by what we witnessed during the COVID pandemic, the virtual world. We need to get together. We need to look in each other's eyes and to speak live. And also, of course, there is always a live in between the sessions, during the breaks, after the sessions. And this is so enriching. It's a real way forward to build relations and to do the things together.